I'm Margot Kushel, and I'm going to be moderating the panel. I think I'm going to just start. I think you have our formal bios. But what I'm going to start in our panel of the interactions between homelessness, hospitalizations, and our carceral system, I'm going to ask all of our panelists to just very briefly give us their positionality or how they relate to these questions. I will say I am a physician and in the safety net, an internist and a researcher who studies homelessness and often sees the effect of health on these sort of dysfunctional systems interacting. I'll pass it to you.
Thanks, Dr. Kushel. Hey, everybody. My name's Alex Visotsky. I work on California policy for the National Alliance to End Homelessness. We look at the data. We look at the practice from communities all around the country to determine what works best to end homelessness in our communities. And then we try to lift up that data, lift up those promising practices, and advocate to places like the state of California to get positive change.
Hi, my name is Randy Carter, and I'm associate producer of The 50, and I'm also a peer specialist, peer counselor in San Francisco. I spent 34 years in prison where I've seen people cycle in and out of prison. And while I'm out here working out in society, I've been out here 10 years as of the 22nd of January. And I'm still seeing people cycle in and out of prisons and jails.
Hello, everyone. My name is Anthony Minacho. I am executive director and one of the providers at Sacramento Street Medicine. Where I come in this discussion is I work on the ground, both from a administrative capacity, but also from a clinical perspective. So, we have we have about 6 or 7 teams in some of the largest homeless encampments in Sacramento. Treating everything from substance use disorders to behavioral health conditions, all the chronic conditions you would see in a primary care clinic, we treat on the street. And so, here to offer that clinical perspective.
Hello, my name is Claire Simonich. I'm the Associate Director of the California Office of the Vera Institute of Justice. We are a research institute and policy advocacy organization that works to end mass incarceration and increase investments in all of the kinds of community care, housing, treatment, and more that will help us address these 3 topics that we're intersecting today. I also come to this as a former public defender who saw a lot of people and clients failed by the system of incarceration who are struggling with housing needs, mental health needs, and I feel very honored to be on this panel to talk about how to make our systems work better.
So maybe I'll kick us off with a question of why are we even talking about these as if these were related? Why do almost all of us in the same breath talk about homelessness, hospitalization in the healthcare system, and the carceral system? How are these intersected? What has gone wrong? Or how could it go better? Maybe since you're on my left, Alex, I'm gonna start with you and just love to have a little bit of a conversation about the why here.
Yeah, I think the reason we end up talking about all these systems in the same breath is really just because we've refused as a society to look our housing crisis in the face and muster the political will to really pursue solutions, right? This is a country where 1 out of every 4 people that are eligible for housing assistance actually receives it. This is a country that birthed modern homelessness by cutting the HUD budget by over 75% in the late 70s and early 80s, right? And so because we have not allowed ourselves to have housing and affordability for poor people in this country as that tool to reach for, we reach for other tools, right? We've reached for the police baton, and we've reached for handcuffs instead of being able to reach for, the stethoscope with adequate health care or house keys for somebody. And unfortunately, I think, we're also seeing people really try to push a narrative that incarceration, that punishment, that coercion is the solution to homelessness in a deliberate attempt to move the focus away from housing, right? This is the whole basis for the current Trump administration for their federal homelessness policy. their executive order in July was called Ending Crime and Disorder on America's Streets. Their efforts right now to change the COC program are really all about creating a large distraction to try to move us away from the fact that they don't want to actually do any of the hard things to make housing affordable for poor people, right? They don't want to actually do any of the hard things to make healthcare accessible for folks. And so instead, they're pushing this narrative that criminalization, that compulsion is the answer. And I don't want to also let our locals get off scot-free in that conversation, right? We've seen as cities, counties struggle with how to address homelessness, they are reaching for criminalization as that tool, right? We have a mayor who just threw his hat in the ring for the governor's race, for example, who has hung that hat on a homelessness policy that says if you don't say yes to shelter after 3 offers, you can be arrested. I try to imagine what that would look like in my neighborhood. I have a woman who lives around the corner from me, who lives in a tent, who stays where she stays because her 91-year-old mother, who's suffering from dementia, lives nearby, and she doesn't want to go across town to a shelter. She has a history of sexual assault. She doesn't want to go into a co-ed shelter if that's what's being offered. And so instead of giving her the health care she needs, the mental health services she needs, the housing she needs, we've decided, actually, let's call you a criminal instead. And so that's a result, right, of us not looking our housing crisis in the face and doing what needs to be done. So instead, we're trying to have all these different systems, and it's maybe generous to call them systems, really trying to triage each other and each other's failures.
Tony, you talked about being a healthcare provider out on the streets. Do you want to talk a little about health problems, substance use, mental health, physical health problems show up and get people wrapped into these systems?
Yeah, I mean, inherently, I was going to touch off Alex's point about criminalization. We see it on the street. You know, this is how the question is how the 3 are intertwined. To me, when you sweep somebody off the street, it's not just their physical health, it's their mental health, it's their spiritual health. And obviously, with the criminalization of whether that's sweeping them, I have patients that they're ticketed, they're then brought into jail for 2 days, they lose all their stuff, all the medications that we just started on them for their diabetes or their depression, their bipolar disorder that they hadn't had in many years are now gone. The insurance won't fill it because they can't refill it within 30 days, so then our team has to kind of backtrack. Another criminalization ends up them being incarcerated. The incarceration then leads to their poor health outcomes, then being put into the hospital. At the level of the hospital, there's no discharge from the hospital to the street. I was just at a local hospital earlier today to try to identify somebody who was found in cardiac arrest in downtown. But the social worker said that in other words, if they weren't in cardiac arrest and they had to let that patient go, they would just go straight back to the street. And there is no coordination in that sense. And so you can see how the incarceration can then lead to worsening health outcomes, can then lead to hospitalization, and without any coordination, I mean, where do we go? I don't see health getting any better. For us, at the street medicine perspective, you know, we go to the people to try to institute these models, whether that's from the hospital perspective. We have ties now to the jail system to where we can hopefully get some records, because that's another thing is data sharing from the hospital to from the jails to the street. It's nearly impossible. And so it makes it all the more difficult, but all the more reason why a clinical spearhead like street medicine needs to exist, so that we can get them the behavioral health care they need, the substance use treatment that they need, at least bridge that gap to their primary care provider or MAP programs or what have you.
Claire, do you want to? And then I'm going to come to you, Randy.
Yeah, I think I'll just add the data to confirm exactly what Tony is seeing on the streets, which is very robust research shows that someone who is incarcerated is 10 times more likely to become homeless in the future. On the other end of that, someone who's unhoused is 11 times more likely to be arrested in the future. So you can see how these things cycle and circle, and if you add the lived experience to the data, and then you think about sort of what our default responses are, you see how we end up with a system of mass incarceration. So unless we are investing in the housing that Alex is calling for, unless we are investing in the street medicine and the care, the default is always going to be incarceration. I'll share a brief anecdote from when I was in law school. It was one of those aha moments, and if anyone here is a teacher or has taught, just know that we all have these moments as students that stick with us decades later, and we think about, and they guide our work and our thinking. But we had a psychologist come into our law school clinic and show us a graph, and the graph was a line graph showing the county jail population from the 1950s to today. It was a straight sort of line up. And on the other side was a line graph showing the existence of mental health institutions for people to live in and get treatment in, which needed reform at the time that they were deinstitutionalized. No doubt, it needed reform, and many of the systems we care about need reform. But the line graph was an exact opposite of the county jail population. And so if we make reforms, but then we don't implement what we need to, and we don't build the housing and the treatment that we need to, more and more people are going to end up in the county jails, which is expensive, and which has some of these collateral consequences, like making it harder for folks to get housing, losing their medicine, losing their children in some cases, and it just makes it harder to get people connected to the care that will end these cycles.
And did you want to talk a little bit about how people fall through the cracks? And
I know that while I was in prison for the 34 years, a lot of people would cycle in and out. I would see people multiple times. They weren't even out long enough to get a California ID, right? A lot of them, we would try to motivate them to go into some type of program. Sad thing is they felt more comfortable being in prison as opposed to going into a treatment facility when they get out. So they would cycle in and out. While they were in prison, they would get medical treatment while they were in prison. When they went out into the street, they started running so fast and they didn't have a safe place to land that those medical conditions, they didn't go to the doctor. In prison, they would get a ducat because they had a primary care doctor in prison who would send them a ducat, let them know, hey, it's time for you to come in and get some treatment or to see me. Once a person gets out and they get into the street, things change. They don't take the time to get a California ID, a birth certificate, a social security card, the documentation that you're going to need to get housing. There was a point when housing, people just thought about just housing first. People would get housing and go burn the housing down. So now they can't get housing anymore. You got guys who have been in prison who have R's on their jacket. So it's certain housing they can't get into. So they're stuck on the street in tents. Immigration. Have people constantly denying services because they're afraid that they're going to get arrested. People have warrants because they're afraid they're going to get arrested. They don't want to communicate with their parole agents or their probation officers. I'm not saying that things won't work out, but it's going to take time. And it's going to take patience. And it's going to have, and these people who are going to have patience to work with these type of people.
Can I just add something?
Yeah.
The way I kind of view like the hospital piece and the incarceration piece is almost like a crisis containment component, right? Like in the hospital, they're so sick they need to go to the hospital, but then they're not sick enough to stay in the hospital, so then they need to be let go, and where do they let go? They're out from the street. Same with incarceration. So it's crisis containment, then they get let go, but where's the follow-up? Many times we get these patients who have their discharge paperwork from their hospital or their paperwork from the jail, and it's like, follow up with your PCP in 3 to 7 days. And it's like, this is not going to happen. And I think the misconception is that their lives are linear when they get out, when really in the real world, it's actually non-linear. It really is non-linear as it gets, because they don't see the living conditions, they don't see all of the environment that they have to be in, and that's why you need specialists like peer support like Randy or street medicine or folks to actually bring light to those policy discussions that are maybe misguided because we're kind of looking at it almost backwards. So
I love that. And I will say, like, I'm a physician who has been accused by many people I adore of having a one-track mind on housing. Because I would say, Claire, that what that graph didn't show was how we have disinvested in housing during that time period, how we have put in rules to sort of criminalize health behaviors like substance use, and how we have just created the condition why there's no housing. Do I think housing alone will solve the problem? No. But those folks, my favorite part of being a physician is that I take care of many people who spent 20 years of their lives in those state prisons. And now they are living lives of incredible, quiet dignity. They're housed. They have the health care that they need. Some of them go to work. Some of them volunteer. Some of them just spend their days with others or even by themselves. And every single time I see these folks, I think what a horror it was that for so many years we thought the answer was to basically incarcerate them in large prisons when they could live in the community. The problem is that community vision hasn't been realized because our healthcare system, I'll own up to it, complete and total mess. But one of the biggest barriers we face in trying to right-size our healthcare system is that our healthcare system doesn't work when people are on the streets. His work is incredible, right? But it is made 10 times harder than it would be if people had a place to live where you could actually reach them in their home than try to do this heroic work on the street. So with that, maybe I'm going to ask, what do you folks think? Maybe, Claire, I'm going to go back to you because you're at the other end. What assumptions do you think people, providers, maybe systems make about people with complex needs that don't really reflect the reality? And what public narratives have sort of taken hold, perhaps, in relation to that has actually constrained our choices or shaped the choices of how we've made them?
Yeah, absolutely. So I think two assumptions really jumped out at me from hearing this conversation we're having up here and reflecting on this question ahead of time. One is that people are static. And I think we especially see this assumption when someone is incarcerated. We assume that they're static. So we assume that if somebody came into jail or prison with a certain mental health diagnosis or a certain level of mental health needs, they will stay that way. In reality, because of some of the inadequate care in our jails and because of the harsh, overcrowded conditions, many people get sicker while they're in jail. On the flip side, I think we make an assumption that someone is defined by who they currently are, who they can be, who they have been, based on what they've been arrested for. And I'll give an example that Randy was bringing up, and I want to just sort of uplift it because I think it's such a strong example of this. So sounds like, Randy, you see this in San Francisco, we see this in LA as well, but somebody might be booked on an arson charge. So a law enforcement officer thought somebody committed arson, they booked them for arson. The public defender in me has to point out they're not convicted necessarily of arson, but they're booked of arson, and they're in the county jails. And there's someone who might be an amazing candidate for services. There's actually, a mental health diagnosis. They would do very well with mental health treatment and housing if they were released to the community. But they have this arson booking. And many service providers are unable to provide services to people who have an arson booking on their record. Folks who have, interacted more with unhoused folks may know that it's not uncommon, for example, to cook or warm yourself with a fire if you're unhoused. And that might have been the reason for the arson conviction. That looks very different if someone gets housing. They're no longer static, and they're not defined by this charge that defined them and is making it much harder for them to get services. If they have access to a job and housing, they may not need to warm themselves or cook that way. So I think the two assumptions that sort of really stuck out for me are that people are static and that they are the offense they were arrested for. That has bearing on the public narratives that shape what's possible for all of us in this room to accomplish in the policy world. So I think many of us live in cities. Many of us here live in California. Maybe most of us live in California. And if you watch the news in California, I'm sure you are seeing constant images of cities that look like there's lots of people struggling in them. And I think we do ourselves a disservice as people in this room who care about building up the systems of care and care about connecting people to housing and treatment if we don't actually get out there and talk about public safety and talk about solutions like housing and mental health treatment and substance use treatment as public safety solutions. Solutions that work, that are proven to work by the research, by the lived experience of people who've gone through them. And we should all be out there loudly talking about, Dr. Gailey's statistics about ODR, for example, this morning. He shared that over 90% of people in LA County's Office of Diversion and Reentry program have not been rearrested for a new crime. They've gotten housing, they've gotten treatment. These are folks who are really struggling with mental illness, very serious mental illness, and these programs work. And so if we are all loudly out there talking about this data, if we're all out there loudly talking about some success stories like the ones Margot is bringing up, even those stories that are boring, right? Like, it's kind of boring to be a person who comes home, goes to work, goes home to your kids. That's not a very sexy or exciting story, but those are the stories that we need to be out there talking about, the success stories, so that we can get the investments that we need in systems that will end this cycle.
Fabulous. Randy, do you have anything to add or about the narratives? You're in the Tenderloin.
Well, I'm not actually in the Tenderloin anymore. I'm all over the city, but I know some of the assumptions is that when our team shows up is that, miracle's going to happen. The person is going to be housed, they're going to get treatment, and, I've been cussed out, people film me, thinking that, we're miracle workers, and it takes time. Some people that we work with act out more than others. Some people are silent, right? And they act out. You have women out there who have been sexually abused, and you offer them services, and there's places that they can't go because the people who have abused them are in the places where she can be seen, right? So she'd rather stay on the street and just run for her life or run for their lives all night long because there's no specific place, because they have communities, pockets of communities out there, and they all know each other. And if someone's 5150, they're making phone calls and they're spreading the word amongst the communities on the street, let everybody know, hey, people are getting 5150 because of this, and this. So people will go on a run. But just the assumption that things can happen just like that, it takes time and it takes patience.
I'm going to say, as a researcher, I love to do research, and there are a lot of things we don't need to research anymore. We have known for a decade what works in a lot of these situations, right? We have an incredibly robust evidence base that you give people housing without requiring treatment in advance, and you provide robust services, that you offer and offer and offer and offer services that are really easy to get. You can keep people housed, you can keep them out of the criminal legal system, you can keep them out of the hospital. We have really robust evidence for certain mental health models that provide intensive services. We have increasing evidence that's having peers and people go and do a community outreach, build that trust that has been broken works. So here's my question. Why has it been so hard to bring these to scale? And then maybe my next question, because we're running short on time, is that there is a lot going on in this policy environment right now. Sort of you can say good and bad, and I'll let people decide what's good and bad. A lot of things going down from the feds. A lot of things at the state level that bring a lot of resources, CalAIM, the BHSA, but also we have to be honest about the impact of the grants pass legislation and the increased sort of Prop 36 and other sort of criminalization measures. I'm wondering, maybe I'll throw it to you first, Alex, why has it been so hard to scale this? And how is this dynamic policy environment going to help or hurt us?
Yeah, thanks for the question. I want to thank you for owning that the healthcare system is a mess earlier, because we blame you personally for that.
It's my fault.
Yeah. Why is it so hard? Every year we start at the state, we start with our housing and homelessness budget at basically zero, right? And all of us that are advocates and policy folks and service providers have to go kind of hat in hand to Sacramento and demand that there be continuous funding for housing and homelessness. That's not how it works for other policy areas, right? Education has this kind of built-in set aside in the budget, and it's hard to imagine that our schools would be able to, adequately educate our children and keep teachers employed if they weren't sure if they were going to have the money to keep their doors open each and every year. But that is what we ask of our service providers and our agencies that are on the ground doing this work. We ask them to keep doing these services on the promise that hopefully we will have the funding to actually keep their doors open. And we know that, they can't really work that way, right? So what we're seeing is, instead of investing in a sustained way that allows folks to scale up and just keep churning out outcomes in a machine, they're in this constant scale up and scale down, staffing continuing to change and fluctuate, unable to keep staff on board because, hey, we don't know if we're going to have money for another 3 months to keep you. That's just a crazy way to solve this problem. And so, one of the main things we need, and we've taken steps in this direction, BHSA was a step in this direction, is to have sustained funding at scale, emphasis on the at scale piece, sustained funding at scale for housing and homelessness coming from the state. We now know we can't count on the feds for that, right? We've got, an administration doing everything in their power to pull money away from California. So the first thing we need to do is really marshal the political will and all be down the street in the Capitol, right, for the rest of the spring saying, hey, this is not housing, homelessness services. This is not something that we can only fund as something that's nice to have, that we fund when the budget looks good, when there's a surplus. This is something we need to fund every single year at scale and keep these agencies doing their work so that we can keep moving people back into housing and keep them in their housing.
Randy and Tony, I wonder what you're seeing. Thank you, Alex, for that. What you're seeing on the streets. Have things shifted, good or bad? Increased criminalization, maybe increased resources. You can now get street medicine covered under CalAIM. Randy, you too, seeing lots of movement.
I think that things are shifting better in San Francisco, where I'm at. I'm seeing a lot of people that I work with taking their medication now. I've had at least 4 people that I worked with walk right by me and I didn't even recognize them. They had to stop me and say hi. You have some who are trying to do outreach work now. That's a good feeling to see people medicated, housed, looking clean, looking groomed, and thinking clearly. That's a good feeling. I remember when I started out doing this type of work, when I became certified drug and alcohol counselor in prison, I thought that I could save everybody. Everybody's going to be saved. It doesn't work like that.
Yeah.
So just seeing the few that I've seen change their lives and just playing a part, that's hope for me.
That's
Yeah, and I'd certainly say that with ECM, community supports, and that kind of being the back end of the clinical piece.
And do you want to say these are now covered by Medicaid for
Certainly,
those?
yeah. So both providing sustainability for programs or a financial sustainability for programs, but also for the services for specifically people experiencing homelessness has been huge. But what I will say in terms of the assumptions, and I think this probably speaks to Alex's point of why is it so hard to keep these things funded, is because there's a misconception or a assumption that availability equals access. And so we have all these FQHCs. We did a needs assessment as we got into Sacramento, and by and large, we had over 1,000 surveys by the people experiencing homelessness on the street. And we found that Sacramento in particular, and I'm sure it's echoed in Los Angeles and other metro areas, that Sacramento is the most resource rich but access poor, because I have somebody who I'm treating for diabetes for the first time, that they've been without insulin for 5 years, no treatment of their behavioral health conditions for 5 years, and I can see the FQAC behind them that we're sitting at probably about 200 feet, and they haven't walked in. And so by this like misconception of, hey, there are programs there are MAP programs, there are behavioral health programs, there are FQACs, there's hospitals, there's clinics, there's these smaller kind of funded programs. We don't necessarily need to fund those things because they're there, but it doesn't necessarily mean that the folks are actually using them. And I'm sure, Randy, you could kind of speak to that. It takes trust. It takes many times more than 1 visit, 2 visits, 3 visits to kind of build that trust over time. We do so through harm reduction principles and meeting people where they're at and honoring their story, unconditional positive regard. But it takes time and training. And Randy and I were talking about in terms of kind of system-wide training in that respect.
And then Claire, before we move to wrap up in a few minutes, I'm going to ask you to perhaps have a less rosy view of policy changes. I'm not sure. I'm going to guess. Tell me about how you think recent policy changes, state, local, federal level, have impacted these systems and their interactions.
Thank you, Margot. Yeah, I want to add to the conversation and to Alex's very righteous call for more funding for the systems that are evidence-based and proven to work, like housing and behavioral health care treatment, that we also know from studying it and from looking at it that incarceration is very expensive. It is a very expensive default approach to some of what we're discussing today. And to Margot's question about state policy, there is a lot of federal policy that's happening that's making all of these things more challenging, that is making us make harder decisions about our budgets because we have less of a budget. But there are also state policies that have happened locally and statewide that are making us spend money in different ways than counties might choose to or want to spend that money. And so at the Vera Institute, we took a look at Prop 36 as one example. And we studied what happened in LA County with 1 year of Prop 36 in effect. And we found that although Prop 36 was discussed as something that would connect folks to treatment and housing, what has happened in LA County for the first year is that we've spent $76 million on incarceration because of Prop 36. We looked at what's that opportunity cost, and we looked at what would happen if we had spent that money in a different way. LA County could have built 2,300 permanent supportive housing units with that money. LA County could have given 9,100 people methadone treatment with that money. And so I think it's important to add into this conversation, especially when we're facing harder and harder decisions about where to put our money with a shrinking pie, investing that money in the evidence-based solutions that work.
If I can just piggyback on that, I saw a study that really kind of like jarred me recently, which was from up in Seattle. They looked at folks who were experiencing unsheltered homelessness, and they took a big sample of folks who had gotten fined while they were experiencing homelessness and folks who had not been fined. And even when they controlled for kind of all the factors that might determine why someone is fined, that group of folks that got ticketed and fined for crimes that were really just a result of being on the street, they ended up homeless 2 years longer than the folks that were not fined. So it's not only that these policy choices have an opportunity cost, that where we're missing an opportunity to do something better. It's we are actively doing harm and pushing people further away from the solution by, ladening them with debt they can't pay, by pushing them away from a case manager that's trying to get them help, by putting a mark on their record that's going to make it hard for a landlord to accept them or make it hard for them to get a job. So I just wanted to add that.
I mean, I think it's hard to underestimate the amount of trauma that incarceration particularly can have for people, and how much time we as healthcare providers are trying to undo that harm we're trying to rebuild that trust that has been profoundly broken. I'm gonna start a rapid wrap-up round here. And I just want you all to envision 2 years from now and imagine a world in which there are fewer people cycling between homelessness, incarceration, and hospitalization. And I want to ask you, just really in 1 minute each, really fast, what will have changed now so that in 2 years we have less of this cycling? Who wants to take that first?
I can start.
Okay.
It's hard to do it in 1 minute, but I'll do my best. So at Vera, we also run dashboards and data dashboards on who's in our county jails and what we know about them. And we run a dashboard about LA County's jail that, as of today's date, shows that 49% of people in the LA County jail are identified as having a mental health need. That number jumps to 70% when you limit it to women in the county jail. And that number has grown 21% in the last 6 years alone. And so if I look down the road 2 years from now, to me, progress looks like reversing that course. We are seeing a steady course of more and more folks with mental health needs in the jail, and I would like to see the number way below 49%. And I think the way to get there is funding the housing, services, and treatment that everybody needs at a much, much more aggressive pace.
Fabulous. Thank you for that. Tony.
Yeah, I think kind of touching off Claire's point, I think from a clinical perspective, having teams that can follow patients out of the hospital, whether that's going back to the street or into a respite care or into a substance use treatment program with a team involved. More often than not, right now, it just doesn't happen. There is no care plan outside of that, one line on the piece of paper saying to follow up with their PCP. Having a team that they know that they will follow upon hospital discharge, I would say, could drastically reduce the amount of behavioral health things and issues and substance use issues that you see in the jails, and the 30-day hospitalization rate, as well as the ED visits. So I think how do you know that is you look at the folks that we do take that do have those measures, and what is that percentage decrease of those hospital readmissions, of those ED visits in that 2-year period.
Randy, what needs to change so that 2 years from now everything looks better?
I need more than a minute, but I'd like for the work that I'm doing in San Francisco with the team that I work with. I work with a team of doctors and nurses and peer counselors 5 days a week, and I'd like to see not just us continues in the next 2 years, but that this expands all through the state of California, because I think that every city who is experiencing homelessness and mental illness deserves to have a team just like I have, with a clinician, peer counselors, and doctors. And we support clients when they are admitted into the hospital and supporting them when they're going back into the street.
Amen. Beautiful. Alex, you've got the last word here.
I think it's we need to see those multi-year stable commitments of funding, both for the housing and for the services that keep people stable when they are in housing. But it's also the narrative. We opened with the narrative. We need to stop thinking people are deficient because they have a mental illness or because they've exited incarceration or because they are homeless. Mayor Steinberg asked a question this morning about whether there's been too much emphasis on the personal responsibility versus the societal responsibility, right? We need to really focus on making sure we as a society, we as folks pushing our government are holding up our end of the bargain before we start, judging others and trying to compel others to make better choices. We need to make better choices at the state before we start blaming people and casting blame on them for our failings.
Wonderful. Thank you all, and thank you all for hanging with us. Thank you.